There's two major classes of antiplatelet medications. One is simply just one drug. It's an NSAID, aspirin therapy there. And then we've got a bunch of P2Y12 inhibitors. So I'll go through those in the antiplatelet section here. All right, so first and foremost, we've got aspirin. So this can basically act as a blood thinner. It can help reduce the risk of stroke and heart attacks and blood clots. Its mechanism of action in cardioprophylaxis, so how it protects the heart and reduces the risk of a future, heart attack or stroke. It irreversibly inhibits COX-1, so that's cyclooxygenase. That's a specific enzyme there. And ultimately, by inhibiting this enzyme, we reduce the production of thromboxane A2. Thromboxane A2 is a potent not a vasoconstrictor, but a platelet aggregator. It makes and helps platelets stick together. Okay, so by reducing thromboxane A2, we have antiplatelet activity, which makes the blood a little bit thinner, if you will, and ultimately its mechanism leads to the inhibition of platelets' action, which they stick together and begin the formation of a blood clot. Also, we use aspirin not just on a chronic basis, but we also use it in acute management of MI. For most patients, the low dose, 81 milligrams, is going to be okay. Occasionally, you may see 325 milligrams once a day, maybe even twice a day in some rare circumstances. So more of a clinical judgment type of situation. The higher the dose of aspirin we go, the more and more likely that we can run into some toxicities such as GI bleeding. Now, I will mention one complication here that's commonly asked in pharmacology exams, and I've definitely seen come up. Reye's syndrome. It's a syndrome where nausea, CNS changes, and in severe cases even seizures and brain problems as well can happen. So this is typically only associated with the use of aspirin following or during a viral infection. And this risk of this syndrome is increased in kids. So, most of your cardioprophylaxis patients are going to be, 40, 50-year-olds plus. So we don't really have to use it too much. But this is why aspirin is generally discouraged in pediatric patients. There are some cases where it may be considered there. But again, usually in our adult patient population, our acute coronary syndrome type patients, our heart attack type of patients, we're not going to worry about this syndrome too much. But in pediatrics, yes, definitely, it is a consideration and something to think about. All right, moving on, we've got the P2Y12 inhibitors. All right, the first medication here, ticagrelor, and these medications are all going to work the same. This medication inhibits adenosine diphosphate by binding to P2Y12 receptors. Okay, so these receptors are found on platelets, and ultimately that cascade leads to platelet aggregation. Okay, so if we block or inhibit adenosine diphosphate, we basically block that cascade that perpetuates those platelets to stick together, and start to form those baby clots, if you will. So, mechanism of action, again, I've got it listed on the other medications coming up here as well. Ultimately, by inhibiting platelet action, we can help reduce the risk of blood clots. Okay, bleeding risk is naturally the flip side, where if we inhibit platelets too much, we are going to increase that bleed risk for sure. This medication can increase uric acid, so that can be problematic in our gout patients. And there is a boxed warning for reduced effectiveness when patients are using aspirin doses greater than 100 milligrams. Okay, so this is a good one to remember, and it's a reason why, if we're on what's called dual antiplatelet therapy after a heart attack, it's the reason why we use the baby dose of aspirin, the 81 milligram dose. Okay, because if we go up to 325 milligrams, let's say, that boxed warning, if we're using ticagrelor with aspirin, that boxed warning comes into play. Another challenge with ticagrelor, CYP3A4 is a major pathway for drug metabolism. So it breaks down ticagrelor, and there are lots of medications that can inhibit CYP3A4. So drug interaction risk with ticagrelor is real. Twice daily dosing is a downside compared to a couple other P2Y12 inhibitors. But we do have historically the best efficacy in the most different scenarios, at least by the guidelines. So you definitely will see, at least at this point, some ticagrelor being used. One other kind of unique thing, it's a false negative results may occur when trying to diagnose heparin-induced thrombocytopenia. Sometimes in an acute care situation, we may see these medications utilized together. Doesn't happen terribly often, but there are certain circumstances where you might see that, and it actually might cause a false negative when trying to diagnose heparin-induced thrombocytopenia. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, next medication, prasugrel. This again, similar mechanism. It's a P2Y12 inhibitor. Main side effect, again, bleeding, as is the case with all of these. We've definitely shown that this is a higher risk medication in the very elderly patients. So it carries a boxed warning in patients who are 75 years of age and older for bleeding risks. Okay, definitely a good one to note. Definitely a good thing to remember there as our patients get older and they're potentially taking this medication chronically. Also, it is recommended to absolutely avoid this medication in patients with active bleeding, which I think that obviously makes sense, but also with a history of TIA or stroke. It does have more potent P2Y12 blocking effects versus clopidogrel. It is once daily dosed typically, and it does avoid some of those CYP pathways as far as enzyme breakdown with regard, comparing it to clopidogrel or ticagrelor. Keep in mind, you wouldn't ever see these medications used together. So prasugrel, clopidogrel, or Brilinta, or ticagrelor, I guess, if you will, by the generic name. So you would never see those used together, but you will see what's called dual antiplatelet therapy, and that's with aspirin and one of these three medications. All right, and the last antiplatelet medication I'll cover here, again, clopidogrel, same mechanism. Brand name is Plavix. Again, used in combination with aspirin or alternatively for those who cannot tolerate aspirin. Oftentimes, you'll see this combo for at least 12 months following a heart attack, particularly with stenting. That may be changed, based upon if the patient is high risk of bleeding, or they're having nosebleeds all the time, or they've had a significant GI bleed, something like that. That's a great time for you as nurses to pay attention and make sure that all these antiplatelet medications or any anticoagulant medication that a patient is on is readdressed by the primary provider. So the monitoring parameters with these meds too, I did want to mention that. We're going to keep tabs on hemoglobin as well as potentially platelets. So we're monitoring for that anemia or blood loss risk. One unique thing with clopidogrel, it's what's called a prodrug. So CYP2C19, this is one of those liver enzyme. It actually converts it to the active form. So there is some pharmacogenomics in play with this medication, and this is definitely a classic one to remember. In patients who are poor metabolizers of CYP2C19, or that enzyme doesn't work as well in some patients due to genetic modifications or changes. So in that setting, poor metabolizers may have the risk of a non-response. So clopidogrel may not work for them, and that would make them more at risk for heart attack, blood clot, and those type of things. Okay, so if we do that testing, which doesn't happen all the time, but it is something that can be done to make sure clopidogrel is effective. If we do that testing and we find out they're a poor metabolizer, there is a boxed warning to recommend avoiding this agent. Note there is one really common drug interaction that I will mention, omeprazole. That's a proton pump inhibitor often used for GERD and peptic ulcer disease and things like that. That can inhibit CYP2C19. Which, certainly it's at least theorized that could impact the benefit of clopidogrel. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology crossword puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse.